later.
Good morning, everyone. Thank you so much for joining, and welcome Raj for joining our virtual session from Health AI Institute. And we are looking great conversation today. And along with that, Gopal have joined, and I like to have a brief introduction about him, and then hand over to him, and he will lead the main discussion, and then I will be moderating Q&A session. So Gopal is a colleague at Health AI Institute. He is a founder of Health AI Institute. Along with that, he's also senior fellow, and he had served 2 US president and 2 governor here in Minnesota. And I warmly welcome Gopal to take the lead for this discussion.
Thank you, Ikram. Thank you. And on behalf of Ikram, my colleague, and myself, we welcome all of you across the world for this discussion on the convergence of technology, policy, and practice in the evolution of healthcare delivery in the United States, and be in a position to serve the people across the world as we enter, particularly at a time, the age of artificial intelligence. We really are witnessing the dawn of the fifth industrial revolution. The establishment of Health AI Institute, and let me talk a little bit about that, really emerged from the conversations with a broad array of stakeholders, including providers, payers, policymakers, technologists, medtech innovators, researchers, educators, venture capitalists, and funders. There seems to be a growing frustration over the size away from our goal of an integrated, patient-centered care that is safe, efficient, effective, and of high value. There is a need, a compelling need for an ecosystem view to ensure that this alignment and happens, and we need to seize the opportunities that artificial intelligence offers for innovation. We must define this new frontier by design rather than stumble upon into that ecosystem by default. And that requires all of us participating in this conversation. Today, our aim is to really drop on the expertise of our distinguished speaker, Dr. Raj Ratwani, and I'll tell you more about him in a moment, and basically learn from him what is the current state of AI. We also want to identify future innovation opportunities. And finally, we want to learn and leverage these opportunities while mitigating the risks and building the ecosystem that can better serve the patients all across the world. Having said that, it's indeed a great honor and privilege to have here with us Dr. Raj Ratwani. I've known him for a long time. He's a distinguished professional, and he currently serves as the director of the MedStar Health National Center for Human Factors in Washington, D.C. He also is the Vice President of Scientific Affairs at MedStar Health Research Institute and is an associate professor at the Georgetown School of Medicine. Raj, his research is focused on patient safety, digital health, data science, and artificial intelligence. Dr. Ratwani has also focused on improving healthcare policy through testimony to the Senate Health, Education, Labor, and Pensions Committee, service on the 21st Century Cures Act, Health Information Technology Advisory Committee, and policy advisement to several healthcare technologists, stakeholders, senators, and the House of Representatives. As we look at the convergence of healthcare technology and government policymaking process, it is utterly important that we have a person and listen to a person like Dr. Raj Ratwani and see and learn from him today. Raj, please take it from here.
Gopal, thank you so much. And Ikram, thank you so much. It's a real pleasure to be here today. And I've known Gopal for quite some time, and have been so impressed with his ability to have this very broad vision and really understand how different components connect AI to current services and processes. And so it's a real privilege to be here today and to join you in this discussion. And what I'm going to do is I'm going to spend the first, maybe 15, 20, 25 minutes just presenting a little bit of the recent work that we've done when it comes to artificial intelligence, and really a focus on patient safety. And then we'll spend the rest of the time on discussion. And just looking at the participant list here, I see that there are several folks on, and one or two folks from our research center, which is fantastic. And so I'll be sure to call out some of the work that they're leading. But that'll be the plan for today. Let me quickly share slides here. There we go. Can everybody see the slides okay?
Yes.
Yep. Great. So let me just start by introducing a little bit more about my background and our Human Factors Center. So my formal training is in human factors and cognitive science. I did a postdoc at the U.S. Naval Research Laboratory and worked in the defense industry for several years. And then in 2012, really wanted to pursue my passion to do work in healthcare and work that would meaningfully advance patients' lives and improve the lives of our healthcare workforce. And so I came to MedStar Health in 2012, and I've been there ever since, so about a dozen years or so. And I can say that I'm truly passionate about the work that I do to this date. And my wife always jokes around with me and says, "Gosh, you haven't stayed anywhere this long. Usually jump around every few years." And for me, the work that we do inside our National Center for Human Factors in Healthcare not only has direct impact, but it also is there's diversity in the work that we do, and it challenges us in so many different ways. So it's a real privilege to be there. Our team is about 20 to 25 people, generally focused on applying principles of human factors to improve safety, quality, and efficiency. And if you're not familiar with human factors, what we do is we seek to deeply understand how humans work, human capabilities, things like memory, perception, reasoning, decision making, and we apply that knowledge to the technology, the work system, the world around us. And human factors is used in nearly every high risk industry that each of us has been engaged with. If you look at aviation, defense, nuclear energy, ground transportation, each of those domains embrace the concept of human factors. They seek to understand how humans work, and they seek to design their technologies to meet those capabilities. And in healthcare, this thinking is relatively new. So we've had human factors for maybe the last decade. It certainly increased in popularity in the last 3 to 5 years. But on a day-to-day basis, we still seem to fall into this trap of trying to push our patients, our providers, all of our healthcare workers to conform and adapt to the work system that we provide to them, as opposed to trying to design our work system to actually meet their capabilities and meet their needs. And so, where AI really comes into this is it affords this new opportunity for us to really rethink our care environments. And what is going to be really important as we go down this AI journey is to not just adopt AI systems and latch them on top of the current work environment, but rather to take a step back and to really think about re engineering the work environment, removing things that no longer need to be there, and successfully integrating AI such that it benefits all. And if you look at the Biden executive order on AI from last October, some of the phrasing in there that I really love is that it should positively augment human work. And I think that is so important for us to keep in mind, positively augment human work. So that's the background on human factors and our team. Now, to set this up, what we are seeing, so we sit inside of a large healthcare system, we're embedded in the large healthcare system. What we see is this tremendous opportunity for artificial intelligence to address some of the biggest healthcare challenges. One of those, for example, is clinician burnout. So, how do we address things like the high turnover rate, no shows, the significant amount of depression that our workforce is going through? Those kinds of issues are pervasive, and many of them are driven by the electronic health record, other technologies, as well as staffing, work conditions, all kinds of things contribute to that. And this is a potential opportunity for artificial intelligence to come in. But you name the big challenge. Whatever big challenge there is in healthcare, there is potential AI solution for it. Another one might be the patient distrust or lack of engagement, the difficulty for patients to understand the health information that they're provided, the limited amount of time that they have with their caregivers. These are really big national challenges that we've been talking about for quite some time. And what is now very interesting is that artificial intelligence has come in and has offered solutions to this. So I like to describe this as the flood of AI solutions. On this particular graph here, you can see that by 2030, the projected investment of AI in the healthcare market is going to be close to $200 billion. This tremendous flood of AI solutions coming in place. Now you can look at that as, wow, that's incredible opportunity. This is going to be absolutely amazing. We can also look at this as, hold on a minute. How are we going to start to differentiate between those technologies that are going to truly positively augment human work, benefit our patients, benefit our healthcare workers, and those that are just going to be another layer of burden, that are just going to be another piece of technology that does not work in our care environment and makes it even more difficult and actually contributes to the work burden and contributes to poor patient outcomes. So where we're focused is how do we start to understand how these technologies work with an emphasis on patient safety, an emphasis on positively augmenting human work. And the big problem I want to call out today is that these technologies are here right now. Healthcare facilities across the country are piloting them and they're adopting them. And currently, there is little regulatory framework. And if you don't like the word regulatory, use the word standards, use the word guidelines, guardrails. Doesn't have to be a regulatory mechanism. There's little out there that is actually supporting the safe and useful adoption of these technologies. That's the big challenge in front of us today. And that challenge, like all challenges, is going to change over time. We see currently that different states, latest news was California, Colorado's done this, have passed their own state-based legislation and regulatory frameworks around AI. But at the federal level, we don't have anything yet. If we look to Europe, the Europeans are a bit ahead of us and have some regulatory frameworks in place. But for us, there's still this challenge of how do we safely adopt these? So that's where our team has been focused. And I'm going to walk you through a few of the studies that we've done with particular emphasis on generative AI, since that really is the cutting edge technology. So before I do that, I always like to just level set on what we mean when we say artificial intelligence. And everybody has a slightly different definition. This particular definition here, which I'm not going to read out loud, is directly from President Biden's executive order. So I like to use that since it is one that is commonly used. But I think actually when we talk about artificial intelligence, it's best described along a spectrum. And so what you'll see at the bottom half of the slide is that spectrum that goes from deterministic all the way to probabilistic. And so when we say deterministic, what we're talking about are really things like rule-based logic, right? You might even say that that's not really artificial intelligence, but we're going to consider it as one form of artificial intelligence. And so when we say deterministic, what it means is that there's really a predetermined response or answer or generation from what is coming from the artificial intelligence. And this has been widely used in healthcare. We have this in clinical decision support. You can think about these as our decision support rules that are sometimes embedded in our electronic health record. And then as we move along the spectrum to the right is where we start to get more complex. And you move into the space of predictive analytics, and then into the far right, which is where I'm going to focus, is the space of generative AI, which is really probabilistic, meaning if we were to closely inspect things like a large language model, it is very, very difficult to understand why the large language model generated the response that it did, right? So it's not deterministic like on the far left. We can't easily trace back and say, aha, this is why this response came to be. There's so many different nodes that are interconnected that it gives rise to complex responses that we cannot easily trace back and understand through those connections. This is the power of generative AI. This is also the complexity for us as we think about its safe use in our care environments. So our focus, as I mentioned, has been number one, to really think about how we can inform guidelines, guardrails, and policy. And we are particularly interested in that space and well qualified in that space because we spent the last decade really pushing for smart and rigorous yet innovative ways to have policies that oversee our electronic health record process. And what we've seen with electronic health records is a relatively weak certification program that resulted in many, many patient safety hazards, as well as significant contributors to workforce burden, right? So if you talk to physicians, nurses, and others, one of the biggest complaints is the burden that's put in by electronic health record. And so we have the opportunity to leverage learnings from that process and from those certification programs to really ensure that we do not repeat those mistakes as we think about what we have to do in artificial intelligence. I'm not going to spend a lot of time today talking about the policy component of this. There's just one more slide on it, but I want to mention it as a key focus area for us. And then what we've been focused on is how do we really start to assess generative AI technologies for safety implications? And to do that well, we have to start thinking about taxonomy. And this is actually work that's being partially led by Betsy Hose, who I see is on the call. And she's been really developing this preliminary taxonomy, which I'm going to share with you. And then we're going to talk about how we've been doing the research with different emerging generative AI technologies to see how they actually perform. So that's really been the focus for our center. And again, our intersection is looking at human interaction with these AI technologies in our complex clinical environments. So here's the single slide on the policy components. There are several different associations and groups that have been stood up. One of those is the Coalition for Health AI, or CHAI for short, which we participate in and is working to set up some guardrails for how we think about artificial intelligence. We believe that this is a critically important step, that we have to have certain guardrails that are in place and that different partners must come together to formulate those guardrails. The best set of guardrails are going to be those that are created through partnership between industry, researchers, other academics, big tech, small tech, you name it. Everybody has to come together to set these guardrails, and we all have to stand by these guardrails. And we have to think about the right incentive structures to make sure that everybody's incentivized to adhere to those guardrails. And importantly, there must be transparency there so that a patient or physician, a nurse that is using an AI system in their clinical care can actually understand, at least generally, what that AI is doing and can actually trust it. We also believe that there needs to be clear standards for safe and equitable use. And we've spent a lot of time thinking about this and writing about this in various JAMA and other editorials, which we're happy to share offline. So that's the 1 minute on 2 minutes on policy. We can certainly take questions at the end and discuss the policy a bit more. What I want to do is transition into talking about this preliminary error taxonomy that we've created, and then show you some of the research studies that we've conducted on emerging AI technologies so you can understand some of the potential safety implications. Now, I want to say at the outset, we are focused on safety, and we are going to be highlighting some of the potential patient safety issues. That should not be taken as us saying this technology is not appropriate for the clinical care environment. We are firm believers that technology has the potential to transform the way that we deliver care. We also believe that when we integrate these technologies, we have to do so deliberately, and we have to have a deep understanding of the potential consequences of these technologies before we jump all in. So in some ways, you can think about us as very pro-technology, but also trust and verify. So we have to have the right precautions in place. We have to have the right processes in place to ensure safe and equitable use. That is generally our stance. Now, this is the preliminary taxonomy that we have developed, really focused on generative AI. And so our goal has been, well, if we know that these technologies are already being used, and we're going to talk about what some of those technologies are, how do we begin to capture potential patient safety issues? And in particular, for this line of research, we were focused on our frontline clinicians, nurses, physicians, advanced practice providers that might be using these technologies. And that's our first line of defense against safety issues. That is, they may witness or capture a near miss or a serious safety event that might have been related to an AI system, and we need to capture that in some way. So that was the lens that we came to this taxonomy with. You can develop a taxonomy for AI developers, that's going to be very, very different than what we have here. So for us, we think about this as there's a model input stage, meaning the user is inputting or there's input to the generative AI system. There's generative AI processing, that's the middle top. And then there's the output layer, what is output by the generative AI system. And when we look at the types of errors, we think about on the input side, you could have things like a wrong query entered, right? So we enter the wrong information. So I'll give you a concrete example. If I'm using something like a large language model, ChatGPT, Llama, you name your favorite large language model, I might query about something like, what is the right medication dose for a 12-month-old? But maybe I accidentally write, what is the right medication dose for a 12-year-old? That would be the wrong input that is entered into the generative AI model. And therefore, the output is going to be different from what I'd probably expect. So that's an example of how we're thinking about this. You can think about an incomplete query entered, and you can think about a misunderstood query. So for example, maybe I used the wrong language, maybe I enter a synonym, maybe I intended one use of the language, but it was interpreted differently. Those are example categories inside of this taxonomy. In the model processing stage, we actually don't touch that because from an end user perspective, we can't see what the model processing is. We just see input and we see output. And from an output stage, here are the main categories that we focused on. Omission, meaning information should have been there, but it's being left out. In addition, information that should not be there is present. The wrong output, meaning just the wrong information is actually presented. The right output, but it's misinterpreted by the user. And then finally, it's correct, but it's not quite clinically appropriate. Okay, so I recognize that at this stage, this language is probably a bit vague because we haven't crystallized it in an example. That's going to come on the very next slide. So why did we develop this taxonomy? Well, I mentioned number one, that these generative AI technologies are now in use in many healthcare facilities across the country. And we see that the use of these technologies is going to expand dramatically over time. And number two, the Biden executive order explicitly called out the need to develop mechanisms to capture patient safety related issues associated with artificial intelligence. And we believe that this is a first step of starting to do that. And Betsy is working hard to get this published and to continually rigorously evaluate this. We believe this is a good preliminary taxonomy and will need to be adapted over time as we learn more, essentially. So let's start talking about some of the technologies. I'm going to talk about 3 different generative AI technologies that are in use. The first is ambient digital scribes. The second is really public large language models, and we'll walk you through a study that we've done where we present patient questions to the large language model. The third doesn't actually fit in the taxonomy, but I think it's very interesting for you to see, which is around public image generators. So if you haven't played with those, they're incredibly fascinating. Let's jump into ambient digital scribes, ADS for short. I recognize that some folks may not be familiar with ambient digital scribe technology. The journey here has been, there were first human scribes. So if we say a physician has an encounter with a patient, we can insert a human scribe that will essentially do all the documentation, note-taking for the physician, and then help generate the note. You can imagine the cost associated with that. We then went to digital scribes or remote scribes. So the idea was, well, now I can have somebody that is listening in on the conversation between the physician and the patient, and that person can formulate the note. Lower cost because we don't need to have somebody physically present. And now with the advancement of AI, we have what are called ambient digital scribes. And the way ambient digital scribes work is you can use your phone or any other device. It sits in the room and it listens to the conversation between the physician and the patient. It is recording that conversation. Then AI, large language model technologies are used against that recording, and it automatically generates a note. There are more than a dozen companies that are developed these technologies, and these are being used extensively across healthcare facilities in the United States as well as abroad. So you can see the potential benefit from this. And the early pilot studies are essentially showing increased provider satisfaction because now nurses, physicians, and others don't have to spend as much time documenting. They can spend more time interacting with the patient. they're showing increased patient satisfaction because now the provider is not sitting there with their face in the computer and is instead able to spend that time actually listening to the patient and interacting with the patient. What we did is we asked a question of, are there potential patient safety issues associated with this technology? And so what we did is we took 2 ambient digital scribe products, actual products are on the market today, and we had 12 patient encounters where we had recorded conversations. So we had the full recording of what a patient is saying and what the physician is saying. And we took 2 physicians and we ran a study in a simulated setting. So in our simulated setting, we went to an actual simulation center. We had a researcher reading the patient script from one of the 12 encounters. We had the physician doing the physician side, and we had the ambient digital scribe technologies running in the background. So we had a very controlled study, and so that resulted in a total of 48 different recorded encounters. And then we had the physicians review the generated note and indicate whether there was an error of some kind. And then our researchers came in and they categorized those errors based on our error taxonomy. Everyone understand so far? Good with it? So basically 48 encounters, 2 products. So here are the results from that. Across the 48 encounters or 48 patients, there were a total of 144 errors that were captured. That amounted to roughly an average of 3 errors per patient. So each time this technology is used, there's an average of 3 errors that are in the generated note. And that's approximately 71% of patients had at least 1 error. So you can see that nearly every patient had an error, and on average, there were 3 errors per patient. We then categorized those into our taxonomy, and you can see the results here. So we collapsed across the 2 products. And you can see that the majority of these errors, over 60%, are actually omission errors, meaning something was said in the encounter, but it was omitted from the note when it should have been present in the note. You can see the breakdown here in terms of additions, wrong output, and correct but clinically inappropriate. Now, what's important to understand is these omission errors have the potential for significant patient safety consequences. And omission errors are particularly difficult because we are now relying on the memory of that provider to recall that something was discussed in the encounter but is not in the note. It's very different than an addition where you can see incorrect text and delete it. So it's recall versus recognition memory. And recall memory is typically very, very challenging for us. So that's one example of the types of studies that we're running. I'll show you the second study here, and then we'll start to wrap up. So this is looking at large language model responses to typical patient questions. So some people wonder, gosh, are patients actually doing this? Absolutely. Patients are taking their discharge paperwork and they're running that discharge paperwork through a large language model and asking the large language model questions. They're asking large language models questions about their own health. It's essentially the next version of a WebMD. And so what we did is we created 3 patient queries. You can see them here. Can I take amoxicillin if I'm allergic to penicillin? What dose of ibuprofen should I take for knee pain? And what are the symptoms of a heart attack? We took those 3 typical patient questions. We ran them through 3 large language models, and we did it 3 times per large language model. And the reason we did it through 3 times is because you get variability in the response from each large language model. So even though it's the same large language model, if you ask it the same thing 3 times, you will sometimes get variability. So there's a total of 27 queries here as our denominator. And across those 27 queries, there was an average of 1.7 errors per query. And there was tremendous variability in the types of errors. And so once again, we categorize these into our taxonomy to help give us a little bit more understanding. And you can see here that roughly 40% of these, there was omission of important information, and about 30% had the wrong output. The information that was generated from the LLM was just blatantly wrong. So again, here you can see the potential for patient safety consequences from the use of these large language models. Now, the last study I'll talk about is in the space of pediatrics. And as I mentioned, much of our expertise and our experiences with electronic health records. And what we saw with electronic health records was that the certification programs were focused on adult medicine. And so what happened was many electronic health records that were now being used for pediatric care were never designed for pediatric care. And we have to understand that kids are not just small adults. They're actual true differences that need to be recognized. And so to get ahead of this, we've called this out in JAMA Pediatrics to say that there are specific differences between adults and children that must be recognized when we develop and deploy AI systems. And I'll just give you one example of this. So this is now turning to image generators. And so if you haven't played with any of these image generators, you can essentially give the image generator any kind of description or query and ask it to generate an image. And so what we did is we said, how do you give a toddler an antibiotic? Now you might be wondering, why would somebody ask an image generator to do that? Well, keep in mind that when you look at health globally, many healthcare facilities across the world need to generate instructional or educational material, not just for their patients, but also for their providers. And it is incredibly expensive to do so. And so many people will turn to image generators to create that kind of educational material. And so this type of question is not atypical if you're thinking about generating material that you might hand to a patient. Okay, so here's the first image that was generated when we ask, how do you give a toddler an antibiotic? Not sure if you have kids or know how to give a toddler an antibiotic. This is absolutely not the right way to do it. You do not take a syringe and put it to the mouth or throat of the baby, of the toddler. That's completely inaccurate. You can also see that this image is really just a nonsensical image. This language up here, it's not English. It's not actually any language. You can see, it may be hard to see on the slide, but there's numbering here that is not in sequential order. So there's many indicators that this is really a nonsensical image. Nonetheless, we see this as potentially dangerous if somebody was to take this and use this. Here's another image that was generated, which is much more appropriate. So this image has a droplet, and this is how you give a toddler an antibiotic, using a droplet directly administered orally in certain circumstances. So you can see the potential risks that are introduced. So let me wrap up, and hopefully we'll have some good discussion and some questions. For us, we are very much focused on developing mechanisms for rapid evaluation of these technologies, not just to highlight shortcomings, but really to understand potential patient safety consequences so that as we adopt these technologies, we can do so safely and we can do so in a way that controls bias. We're focused on continuing to develop this taxonomy. We're firm believers that to understand how this technology is actually being used, we need to have a way to characterize the types of errors that are occurring. We are also very much focused on how we can start to display information about uncertainty in these models so that our end users have a better idea of the information that they're looking at. Many of you may have seen the news around the hurricanes that have tragically hit Florida and moved up the eastern seaboard. If you think back to when you look at the representation of the potential pathway of those hurricanes, there's always uncertainty displayed because there's uncertainty in the weather models, just as there's uncertainty in the large language models and other AI tools that we use. And if you think about those weather maps, there's generally a filter or a cone that shows the likely path and then all the different trajectories. So it's giving the end user, it's giving us an idea of uncertainty in the model and where this hurricane trajectory might go within margin of error. And we typically don't do that when we think about artificial intelligence, whether it's clinical decision support or these large language models. The model has uncertainty, but we're not showing that uncertainty to the end user. And by actually showing that uncertainty to the end user, we can likely build better trust in those technologies and better use of those technologies. And finally, we are really trying to develop out different ways to better assess and understand patient direct use of these technologies. It's very difficult to truly understand how pervasive this is from a patient perspective, simply because we can't see everything that patients are doing. And so this is a big area of focus for us as well. So I'll stop there and I will pull these slides down. I want to thank you all for taking some time to listen to that and looking forward to discussion and questions. Gopal, I think you may be muted.
Yeah.
There we go.
Thank you again, Raj, for this wonderful learning opportunity. I see several areas that you're focusing in, and the couple of that I would like to seek your help to tease out a little bit more before I pass it on to Ikram to take the other questions that he may have fielded so far. So the first one is taxonomy. You talk a lot about that, the importance of it, significance of it, and your focus. What are you seeing as in terms of challenges towards moving towards the, if there's a word to be used, right taxonomy ultimately, or a better use? Tell me a little bit about that.
It has been incredibly challenging developing this taxonomy. And so we continue to say this is a preliminary taxonomy or a pilot taxonomy. We currently don't have a good sense of all of the different types of potential errors that might emerge from large language model use. That's just a fact. It has not been used enough. It has not been studied enough for us to really understand the entire spectrum of errors. And so one of the important things that we have to do from not just a research perspective, but also from a deep industry perspective, is understand the boundaries of this technology. And so this is our preliminary mapping. We imagine that there are going to be several more categories that emerge. And we also are looking at this from the front end user or the frontline user perspective. We need to understand this from all angles. And so I think this is one area where true partnership with the AI developers is going to be critically important. We also have to recognize that our frontline users are only going to be able to observe and see so much. And we're going to have to develop some other very sophisticated ways to capture potential errors here to really understand the safety consequences.
So Raj, you've also talked about standards, right? Coming up with a way, uh, how you want to describe that. So you've got efforts going on taxonomy, you've got some challenges, you need to work with the developers, but what about the delivery systems? Are they willing to work together? Because each delivery system has its own priorities from a business perspective. And in the competitive marketplace, that's understandable. But what comes in the way of standardization is each vertical delivery system looking after its own methods and approaches, again, to better serve the patient. I, do you see an opportunity? Would they be willing to work, or it's hard to bring them?
Yeah, Gopal, it's a great question, and I know you have tremendous experience in this area, so I'll give my thoughts and please share yours as well. I think that fundamentally it is a competitive marketplace, and I think each facility or system is going to take whatever technology is going to work best for them, and they're probably going to configure it and customize it to maximize the benefits for their particular patients and for their particular workforce. And I think that's actually something we want to enable, right? We want to enable people to be able to do what's best for them. Having said that, a basic set of standards, I think, are critically important to maintain safety and to control for bias. And the example that I'll give is from the driving industry. You can also use this, the aviation model. If you get into any car in the United States, there's standardization, regardless of whether it is an expensive car, an inexpensive car, it doesn't matter the manufacturer. There are basic standards that are adhered to. There's standards around colors, there's standards around symbols, etc., symbology, iconography, you name it. And so that's the level of standardization that I think we really need to focus on for AI and other digital health technologies. Where there's a clear connection between the design and safety, we need to have some kind of standardization. Where there's less of a connection or no connection, enable as much customization and configuration as you'd like. That I think is an important perspective.
Well, I appreciate that. Ikram, I'll pass it on to you because I've got a lot more questions, but I want to hand it back to you, Ikram. You may have some questions over there.
Thank you so much, Raj, dwelling in these very, very important area with which we have been, Gopal and I have been talking and we are hearing from so many experts in this field. I think we have to delve more deeper into. But here are a couple of questions I've received, and I will go with them, trying to see that's how many of them we are able to achieve in this short meeting. So, Raj, you have worked closely with the various federal agencies and industry partners. Can you talk about the biggest barrier to scaling AI solutions in healthcare across different regions in the healthcare system?
Yeah, it's very challenging right now, and I think there's strong industry push, understandably, because I think people are excited about these technologies and there's ability to do great things. And I think there is a desire by different healthcare facilities and systems, small and large, to adopt these technologies because of some of those very big challenges that I talked about at the outset on slide 2 or 3. Currently, the regulatory environment, I think, needs to be streamlined and brought into alignment. And what I mean by that is we have different states that are now passing regulatory and legislative efforts around AI use, which is going to lead to a patchwork of regulatory rules that if you're an industry developer and I'm now deploying a technology in California, I have to make sure I adhere to those rules. And it's a different set of rules in Colorado and a different set of rules in Wyoming. So this patchwork is not going to do well for us. And we saw how this unfolded with telehealth, where every state had its own telehealth regulatory environment. And it wasn't until COVID when there had to be all this emergency legislation passed to dial some of that back. We can't have that happen with artificial intelligence. We need a standard set of guidelines and rules that operate for us nationally. Otherwise, we're actually going to hamper innovation. So I think that's one thing that needs to happen is we have to get rid of this patchwork mentality, and we need some kind of national or federal movement here. Number 2 is each of the different federal agencies, what was known as the Office of the National Coordinator, the FDA, the Office for Civil Rights, each of them are passing different rules or thinking about different rules, and they're not in alignment. And that poses several challenges for AI developers and for the healthcare facilities that are adopting these technologies. Because we all are each working to now adhere to these different set of rules that may potentially be in misalignment. So as an example, the Office for Civil Rights has said healthcare facilities, any covered entity, they're responsible for assuring there's no bias in AI technologies they adopt. That makes perfect sense, and that's a very important rule. And it's important that there's shared responsibility there, that doesn't just fall on the healthcare facility, but that the AI developer and other partners are thinking about ensuring that there's no bias and enabling healthcare facilities to look for bias. Separate from that, the Office of the National Coordinator has said, if you're an EHR developer and you're including a AI algorithm or system as part of your base product, you must be transparent about certain data elements. However, they are not requiring testing for bias. They're not requiring testing for safety. And there's no minimum threshold as to what would be considered safe or fair, right? And so it'd be very important for us to bring all of those together into alignment. And I think that model should be shared responsibility and everybody's adhering to the same set of guidelines or standards. And this kind of mismatch right now, I think, is leading to a lot of confusion. It's leading to a lot of wasted resource. And importantly, I think it's going to lead to exacerbating inequities. Because if you are a small healthcare facility, let's say a federally qualified health center, and you're considering adopting an AI technology that's going to help your patients, if you don't have the resources to ensure no bias, you can't adopt that technology, which means you must employ a data scientist or somebody else that can do that kind of vetting. So that is putting a tremendous amount of burden on that healthcare facility, right? We have to figure out how we raise the tide for all healthcare facilities, all boats, and not just enable the large healthcare systems that can employ informaticists and data science to do the vetting to adopt these technologies.
I think that's a great insight, and I'm hearing that with a lot of industry partners that if they are based in different states like California, they have very high regulation and a lot of different regulations coming up. And some are very stringent for adopting. And if in case of federally qualified health system, if they are going to thinking to adopt some of those versus applying into California versus Colorado or in Michigan is a very different AI system they or regulation they have to manage.
Right.
And institution like that, FQHC, it's very difficult for them to have so much resources that they can tweak that to those states. And I'm hearing that federal health system is not able to cope up with managing a greater standardization regulation in that regard. So I'm like to switch to the second question, which is from the audience here. Yeah. And is that in high reliability field like aviation and healthcare, we analyze mistake, but for instance, for the NTSP investigates plane crashes and healthcare institutions conduct root cause analysis, how might AI be used to predict and use error before they happen? Also, could AI help us study when things go well to improve care quality and reduce clinical burnout?
It's a great question. We this talk was very much focused on the patient safety consequences that emerge from AI use. The other side of this, which is so critically important and so much opportunity, is how do we leverage AI, the power of AI, to address existing patient safety issues, right, and prevent other patient safety issues. So, number one, I would say there is a lot of effort being put into early warning systems. Early warning detection of sepsis is probably the most typical predictive type of algorithm that we see. And I think there's tremendous power there. And we're going to see several of those different kinds of AI systems built out over time. It's going to be important that we rigorously assess them for safety and bias, but that's not the point. The point is that there's tremendous opportunity there. The second thing that I would say is, historically, we have seen this really nice transition from or addition to not just reporting on patient safety issues after they happen, but really developing different types of informatics-based algorithms to predict when there may be a safety issue or to look at patterns in data to see where there might be a safety issue. I'll give you two examples. One is by Dr. Jason Edelman, who's at New York Presbyterian, and he developed at the time what he called a retract and reorder tool. So the idea is that if we look at patterns in EHR usage data for when a provider orders a medication and then within a few minutes cancels that order and places it again on a different patient, it's an indicator of a wrong patient error, right? A very neat way of saying, gosh, we can capture some of these issues without waiting for people to report them. And once we see a pattern of these, we can go in and we can try and address it by fixing the electronic health record or any other part of the system. Another one is to look at things like prescriptions for Narcan, which is used for opioid overdoses. And if we look at the pattern of Narcan use, we might actually find where a physician mistakenly ordered the wrong dose of an opioid and then had to prescribe Narcan to address that. Again, using the data to understand a patient safety issue. And so I think we can accelerate those kinds of rules and those kinds of algorithms using artificial intelligence. And that's going to be a really big opportunity for us. And then I think the next part of the question was, could AI help us study when things go well and improve care quality? And I think absolutely. I think these are all different territories that we need to investigate. And I think much of the focus right now are on things where there's a direct connection to financial benefit for healthcare facilities. So things focused on workforce burden, clinician burnout, and early detection of key disease states. That's typically where AI is being focused right now. I think what we're going to see is expansion into many of these other areas, like addressed in this question, that at first pass, people might say, oh, I don't see the direct financial connection, but there is one, right? And there's human benefit there. And so I think we're going to see expansion into those areas over time.
Yeah, great insight. I'm moving to the next question from the audience side. Uh, is that we are seeing a lot of synthetic data, synthetic artificial data these days, especially for the training of the AI. So the question is that increasingly we see the use of synthetic data to train the model to handle challenges around the bias and privacy in the healthcare. What are some of challenges around this, and how can we leverage use of synthetic data safety?
It's a great question. I think there's a clear role for the use of synthetic data to develop these algorithms in the early stages. And what I really like about the use of synthetic data is that it opens up the opportunity for many, many AI developers, data scientists, and informaticists across the country that would otherwise face barriers accessing privy healthcare data. Right? That's a big challenge for us. Is we have to remain HIPAA compliant. We want to be aware of PHI, and so we can't just unleash our data to anybody to develop models. Using synthetic data, we can do that. And so that increases the talent pool that could develop AI systems that can benefit our patients and our healthcare workers. And so I think the role of synthetic data is critically important. I like to think about this as the trajectory in terms of development. And so I think early on, use of synthetic data is important, is a good way to get started. And when we see that there is potential benefit to those algorithms that are based on synthetic data, we move it to the next stage, which is now starting to apply those to actual patient data. And then to the next stage, which is starting to run those algorithms in silent mode inside of our clinical environments to see how they're actually operating. And then we can finally move to a potential live pilot. So I think synthetic data plays a key role in that early stage to open this up to lots of different developers.
Yeah, very interesting insight. Another question is that AI has made impressive stride in healthcare, including other industries. But what do you think are some of the ethical considerations or potential unintended consequences we should be more proactive about addressing?
Well, I think probably and they're really smart ethicists that can answer that question better than I can. One area that I'll focus on is how do we really have conversations with our patients about the use of AI in their care? And at first pass, that might seem like a very simple question. You let patients know about AI use every time it's being used, and give them the opportunity to opt out. But the reality is that AI is embedded in the electronic health record in many ways. It's embedded in other care processes, and it's impossible to opt out. You could not physically opt out of having AI apply to your data. And so now this becomes, it's a part of informed consent. And so we have to think about how we integrate that informed consent. And we have to think about how we have conversations with our patients about the role of AI, and especially if there's misalignment between the AI and the actual expert. So the example I'll give you is radiology. Many healthcare facilities across the country have adopted algorithms, very, very sophisticated artificial intelligence that will read certain images. And what we find is these AI algorithms can capture um, issues in those images that the human radiologist cannot. And so if the human radiologist does a read, does not detect anything, the AI algorithm does a read and detects something, how do we talk to the patient? Do we say to the patient, our human radiologist didn't find anything, the AI algorithm did find something, and now we have to make a decision. Do we continue with more aggressive testing, or what do we do? So those are difficult and different conversations than we've had to have in the past. And we're going to have to think about what we do there and how we do it.
Thank you so much, Raj. I think I try to cover as many as question, but we are very close to the time and looking to wrap up now. So what is your final thought around when we are thinking about safety of AI? We have learned a lot, but which way we should what's your thought on taking a final lesson for our audience here?
I think I would end with we have to keep safety and bias top of mind. And we get very excited by these technologies, which is fantastic. And there's a clear role for these technologies. But we must pause very briefly and ensure that we have the right processes in place to promote safety and equitable care. And that's the right way to do it. And we have to now take the time and actually develop the processes to do it.
Thank you so much, Raj. I like to circle to the Gopal here to see that what's his thought before we
Well,
close on.
Raju, we've got a lot more questions for you, and we would love to have you back again. Thank you so much for taking the time to be with us and sharing your ideas, your experiences, and also challenging us to think differently, and which I think we need to. So we hope to get you back again. And thank you to all the audience for your fine questions. Appreciate it, and hope you've enjoyed this learning experience. I have. Thank you, Raj. Take care and be well.
Thank you all. Take care.
Thank you, everyone.